Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi everyone, welcome back to another episode of Working Smarter. Today we're joined by quite a few special guests throughout our podcast who's going to talk us through a lot of the different changes that CMS has proposed and are in the final rule that center around physician payment. And we know that these regulations are changing rapidly and they seem to change every year. So we're trying to keep all of you up to date as much as we can about what's going on. So you may remember from our podcast about this last year. There's a lot of really positive key takeaways CMS has said in their final rule that are indicative of it's a great time to work with VillageMD. So talking about further improvement in TCM and CCM and care management, quality payments, and value-based care. So we're very excited about what this has to hold for VillageMD in the future, and we're just going to walk you through some of the changes. We're concentrating today on quite a few major changes that have happened, or ones that apply most specifically to primary care and the services that VillageMD is offering, but there is a huge laundry list. We're more than happy to walk through some of those in more detail. If you want to reach out to us to get more information, or if you want more information on one of the ones that we cover today, please comment or send us an email, and we will try and do special episodes about more of these changes. We're going to hand it off to Lisa Feiss. She is a director of revenue cycle in our Houston office. Talk more about physician fee schedule, RVU, and the PTOT changes.
Okay, so today we're going to talk about the 2020 final rule. Part of that is the physician fee schedule, of course. And when we talk about the physician fee schedule, we talk about services or CPT codes that are rendered and how those are calculated. Each service that is provided is assigned a relative value unit. And the relative value unit is comprised of the value of work the physician is doing, as well as the practice expense to deliver that service. There is also malpractice that is calculated into that relative value. And then once the relative value for the service is determined, that is actually multiplied by the current year conversion factor to get a rate that Medicare publishes each year. So this year with the conversion factor, we don't see much of a change. 2019 current rate is $36.04 compared to 20, which will be $36.09. Relative value units are revalued every 5 years with the exception of some codes that are revalued more often based on claims data as well as quality reporting. For instance, we're going to see a significant increase for 2020. The TCM codes were revalued. And some data that has been published shows that in 2018, there were 1.8 million claims billed for TCM services for Medicare beneficiaries compared to 9.5 million discharges. So in events like that, data that's reported, it does allow codes to be revalued, and it allows providers to get additional reimbursement to provide those services. 2020 E&M changes will pretty much stay the same. There is a small increase of 1%, not really notable. The next change that we'll talk about with 2020 final rule is therapy services. So there are a couple of changes. There are two new modifiers that will be reported. The modifiers are in relation to therapy assistance. So modifiers will be used if the therapy assistant provides the service in part or in full. In 2022, those modifiers will drive reimbursement for physical therapy assistants and occupational therapy assistants. They will be paid 85% of the Medicare fee schedule. Also, for 2020, there's some language that has been changed in the final rule. There is not, the language of therapy cap is not being used. However, they are calling it limitation. Each Medicare beneficiary will receive $2,080 as a limit for therapy. Although providers can still provide and bill for therapy and be reimbursed with the use of a KX modifier. Using the KX modifier should be done with caution. It does increase our risk for audit. These services can continue to be rendered as long as they are medically necessary, and our documentation supports that.
Now we're going to turn to Christy Lee, who is the director of professional revenue cycle for VillageMD. She's been on the podcast many times before, and we're so happy to have her back. She's going to be talking about CMS's Patients Over Paperwork initiative. They initially launched this, I believe, last year, and they've had some fairly major changes in this new rule. So, Christy, how about you walk us through some of these?
I was really happy to see the proposal when it came out that CMS is going to maintain their initiative to reduce the burden of documentation on providers going into 2020. These changes are going to be pretty significant for 2020, really helping to reduce the overall documentation requirements for especially our primary care physicians, as they are now going to be allowed to have their staff capture the chief complaint, document the history and exam elements, and the physician can basically review and approve those in the medical records, so they do not have to redocument these elements. So this will be a tremendous reduction in documentation burden for them and should streamline the process of completing notes. There are a couple other changes that are also significant for 2020. One being that providers will no longer have to redocument a full history and exam if they have already captured that in a previous visit. They can simply refer back to that, and that would be proof of documentation in order to support their level of service. The other change comes for home visits. They no longer have to document the medical necessity to treat a patient in the home. They can simply go out and provide that service without having to come up with a medically necessary reason to have provided that service in the home. Some other great changes, I don't know if you remember, but last year when CMS came out with their proposal, they were going to condense down all of the E&M levels. Levels 2 through 4 were become a single level, along with some prolonged service modifiers to be able to recapture some money based on the time spent with a patient. Luckily, with the new change coming out for 2021, they are going back and going to keep the E&M levels intact, except for one change. They will be changing the 99201 will no longer be an option for new patients. They felt that 99201 and 99202 were basically the same CPT code because they both required straightforward medical decision making, but we will maintain all 5 levels of service for our established patients. In 2021, we will also have some significant changes to how providers are selecting their E&M code. Obviously, they can maintain and continue doing what they're doing today in the current state, or they can go with the new guidelines, which is a lot simpler and will allow them to pick their E&M level based on either time spent with the patient or based on strictly medical decision making that is performed during the visit. The expansion of these codes will also include verbiage changes in the CPT book to add more clarification to what each level is, which will allow you to select the code more easily and reduce the amount of documentation needed to justify that level of service. When they talk about total time spent for the encounter, when you're selecting that level, those will also change, as total time will now be the total time spent that day of the encounter working on the patient, and not just the amount of time in the exam room face-to-face with the patient. There are also going to be clarifications coming out around medical decision making, making the 3 elements more clear. They're basically going to increase the number of problems being addressed to clarify it to be what's the complexity of the number of problems being addressed, as well as amount of data being reviewed. They're going to add the word analyzed to make sure that you're really showing how much medical decision making is being performed during that visit. And then, of course, maintaining the risk of complication and mortality of the patient as your key decision makers when you're dealing with medical decision. Obviously, these changes don't go in effect until 2021. So this time next year, I'm sure we'll have some more information around these specifically.
Now we're going to be joined by Mary Hughes. She's a director of care management for VillageMD, and Mike Lerner, who is a vice president of value performance in our Houston market. And they're going to walk us through some of the transitional care management and chronic care management that we're seeing. It's fairly substantial changes that they're making. Can you guys just walk us through some of the many changes that are happening in this space?
All right, there's a lot of good work happening in the care management space around billable care management services. First up is in the TCM, with billable TCM. Year over year, there's increased revenue coming from TCM, but CMS recognizes that there's increased opportunities based off of the discharges that are being accounted for versus billable TCM. We're going to see increased revenue for billable TCM in 2020. And as we all know, there's substantial benefits related to providing TCM services to our patients. Naturally, that's going to be reduced readmission rates, lower mortality rates, and decreased healthcare cost. And additionally, patient satisfaction, just better care. So for the 99495, those moderate complexity patients, you're going to see about a 13.5% increase in billable TCM, equivalent to a $22.70 raise per billable event. And for the high complexity medical decision making, you're going to see a 6.2% increase, otherwise a $14.74 increase to the billable services.
Mary, like you mentioned, there's a lot of good reasons to encourage providers to adopt TCM. And here at Village, we've seen the proof of that. We've seen that when patients go through our post-discharge process and have a TCM visit with a physician, that we see a readmission rate that's about half compared to when patients don't go through that process. And so we want to continue to encourage the utilization of the post-discharge process and TCM. Any idea, Mary, how many TCM visits we've billed so far this year between our Houston and our Indianapolis markets?
Maybe like 2,000?
2,000 is close, but it's actually about 5,000 visits so far this year. And again, we want to encourage providers to adopt that process and make the process easy for providers so we can get that incremental reimbursement and continue to prevent readmissions, which cost the healthcare system on average $15,000.
Next up is CCM. CMS, like I said before, is recognizing the value of care management services, and they are increasing the billable revenue for CCM, adding additional G codes. So for incremental 20-minute blocks of services, the providers can bill for additional revenue, enabling more access to services for care management and getting reimbursed for the great work that they're doing. Lastly is the introduction of a new principal care management, or PCM is what they're calling it. Unlike CCM, which the requirements say you have to have 2 chronic conditions, PCM says there's a single chronic condition requirement, and the patient has to have received care for 3 to 12 months. And similarly to CCM, they have to be at risk for hospitalizations and or the condition has likely resulted in a recent hospitalization. The care management services have to have a disease-specific care plan as opposed to CCM's comprehensive care plan, and PCM cannot be billed with other CCM codes.
And last but not least, we're joined by Joanna Lozer, who is a director of clinical quality for VillageMD, and she's going to walk us through some of the quality measure changes that we're seeing in the space. CMS has been trying to do some streamlining. They're changing sort of how the program's being run, who is involved in the program. So there's a lot of differences in this space. And Joanna, can you help guide us through this?
So regarding quality in the 2020 final rule, CMS is working hard to reduce the burden of quality reporting and all the fees and extra work that requires. The reducing the burden also is reducing the paperwork, as previously discussed. I must caution, though, that doesn't mean we don't have to still document for quality measures. That is something that has not changed, so there might still be some work involved as far as documentation. But overall, CMS is working to reduce the work and the burden. So they are looking at the quality measures to make sure that they are meaningful and that they actually direct care to improve quality and outcomes for patients. So quality measures in the 2020 final rule, basically for MSSP, Medicare Shared Savings, addressed only 2 measures, and that's preventative care and screening for tobacco use is reverting to pay for reporting instead of pay for performance. And then the ambulatory sensitive condition acute composite is reverting also to pay for reporting. That way we get full credit for both measures just for reporting those measures. In 2021, the tobacco screening will resume and pay for performance, and in 2022, the ambulatory sensitive conditions will revert back to pay for performance. The MSSP finalized scoring will remain as with quality at 50%, improvement activities 20% with automatic credit for ACO participation, and promoting interoperability 30%. Overall, these are positive changes. So merit-based incentive payment system, or MIPS, this is related to
providers who are not part of our ACO or MSSP or NextGen ACO. This is a requirement that all providers have to report quality improvement measures to either earn up to a 9% payment adjustment. If they fail to report these quality measures, they can be penalized up to 9%, which is quite a large chunk of money. In 2021, MIPS will become the MIPS value pathway. That is about all we know about this program at this point. We know that it's going to be encounter-based through the continuum and will include specialty measures from supporting specialties, but they have not finalized or defined the rules or definitions yet, so that is still pending. We do see this as a positive, as it is enticing for providers to join one of the VillageMD's MSSP ACOs to avoid the burden and the additional work of reporting those quality measures.
If you're watching along with us on the screen, you can see that there are different effective dates for each of these things. Some of these are starting to come in place next year or not until 2021. These things are changing in just this final rule, and that additionally more things are going to be changing potentially next year. We never know what to expect with CMS, but we want to put out a question to all of our listeners. What are our next steps to prepare for all these changes? And what do you need to know so that this positively affects your practice? We would love to hear from you. If you have any further questions, comments, you want to learn more about one of the changes that we just talked about in this podcast, please reach out to us. We'll try and keep you as up to date as possible on all of this.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.